Very good afternoon, and thank you, those of you who have joined us today. I'm Dr. Aparna. I take care of the neonatal ICU at KIMS Cuddles, Kondapur, Hyderabad. Today, we are going to discuss something which we deal very often day in and day out, some common case-based scenarios in neonatal sepsis, and how to take evidence-based scientific decisions on the optimal choice of antimicrobials in these scenarios. So this discussion is entirely going to be based on case scenarios that we deal with in real time, every day, day in and day out. The first case is a 9-day-old newborn who is born at 38 weeks of gestation by elective cesarean section with a birth weight of 3,500 grams. The baby is brought to the hospital with complaints of abdominal distension and poor feeding for last 2 days. This baby was fed on formula on day 1, discharged on day 3 from the hospital, and subsequently has been on breastfeeding as well as formula feeding because the mother perceived inadequate milk supply. So baby presents to us on day 9 with an admission weight of 3,300 grams, which is 200 grams less than the birth weight. On examination, she was lethargic with an axillary temperature of 37.8 degrees Celsius, which is indicative of hypothermia or fever. On further examination, the abdomen was distended, but it was not tense or tender. There were no gastric aspirates. So to summarize, we have a full-term baby who has presented with symptoms suggestive of late-onset sepsis in the form of poor activity, lethargy, and abdomen distension. We all understand that the other differentials in this scenario would indicate surgical conditions. If there is significant distension, we would consider lower gastrointestinal obstruction like intestinal atresias, like Hirschsprung disease or anorectal malformations or meconium ileus. If there is paucity of distension and predominant bilious vomiting or bilious aspirates, we would consider upper GI obstructive pathology like malrotation. In this particular case, a thorough evaluation for potential surgical causes was negative for any obstructive causes, and we are dealing with a case of possible late-onset sepsis. Now, we decide to admit this baby and send complete blood counts, which includes hemoglobin, white blood cell count, and a differential count, which will give us the absolute neutrophil count and C-reactive protein, blood culture, and start the baby on intravenous antibiotics. We also plan to do a lumbar puncture and urinary examination for urosepsis. Now, the question here is, what is the most preferred antibiotic regimen for this neonate who seems to be relatively stable, hemodynamically stable, not requiring any respiratory support, with signs suggestive of late-onset sepsis in the form of encephalopathy as well as abdominal distension. So these are the following 4 options: ampicillin and gentamicin, which is still recommended by the World Health Organization as the empirical first-line antibiotic of choice in neonatal sepsis. The second choice, which is now often taken up in some neonatal units, is a combination of ciprofloxacin and aminoglycoside. The third option is piperacillin tazobactam and amikacin. And the last option is a combination of 2 fairly broad spectrum antimicrobials, which have excellent coverage for gram-positives and gram-negative bugs, vancomycin and meropenem. So let's take this question, and to answer this question, we need to consider some relevant factors. These factors include the local prevalence of antimicrobial resistance pattern, the local microbiome that is prevalent in that particular region, which includes the common bacteria that are isolated in otherwise sterile body fluids. This is usually prepared once in every few months by the microbiology team of most of the hospitals. So they circulate this data to us, which talks about the prevalence of various gram-negative and gram-positive bacteria, or possibly other organisms, including fungi, that are commonly isolated from blood, urine, CSF cultures that are sent from the hospital, from different ICUs. The data also should include the sensitivity pattern of organisms that are grown in our own center. The coverage in newborn babies particularly should include both gram-positive and gram-negative cover. We will discuss why this is important. Very important is to avoid reserve antimicrobials straight away, at least as empirical coverage. When we still are awaiting microbiological results, it is always good to avoid the reserve antimicrobials and try to downgrade as per the sensitivity report. So as soon as we have the culture sensitivity report, and if we are fortunate to actually grow a microorganism, then we must use the relevant antimicrobial susceptibility pattern to downgrade antimicrobials wherever there is an opportunity to downgrade to a less to an antibiotic with a lesser coverage pattern. Now, in order to answer this particular question, we'll try to answer the first part, which is the local microbiological profile that is commonly isolated. So if we have to look at data from low middle income countries, and particularly in the context of India, the pattern of microbes or bacteria that are commonly isolated from neonatal units, this is from intramural centers, is as follows. So up to 60% of the bacteria that are isolated from blood, CSF, and urine cultures tend to be gram-negative, and up to 35% of isolates tend to be gram-positive, and the remaining small proportion is accounted for by the fungal and other pathogens. So 2/3 gram-negative and 1/3 gram-positive is what we often see in low middle income countries. And this is also true for Indian subcontinent. So we have data that periodically comes from the National Neonatal Perinatal Database, which is data that is collected from up to 18 tertiary care neonatal intensive care units from across the country. And they compile their data with respect to various morbidities, including sepsis, birth trauma, mortality pattern, and they keep publishing this periodically. So the NNPD database as of 2003, but this is not very recent though, this says that among all the bacterial isolates in NICUs, Klebsiella is by far the most common organism, accounting for nearly 1/3 of all the bacterial isolates. Up to 32.5% of all bacterial isolates were Klebsiella. So this was the single most common organism that was isolated, followed by among the gram-negatives E. coli. And however, the next second most common bacteria that was isolated from neonatal units was gram-positive bacteria, which was Staphylococcus aureus, accounting for 13.6% of the isolates. In the NNPD database, the incidence of fungal sepsis was not explicitly reported. Whereas another publication that came from low middle income countries, which came up in Lancet 2005, gave a fairly similar distribution. Again, Klebsiella topped the list with 23% of all the bacterial isolates, again followed by Staphylococcus aureus coming from the gram-positive group, accounting for 16.3%, becoming the second most common bacterial isolate. E. coli and other gram-negatives came in later. Cons, the proportion increased from 6% to around 12% in this publication, and fungal sepsis came up with a 2.1% proportion among all bacterial isolates. Now, this need not be the same across all neonatal units. The proportions are significantly different between intramural and extramural units. And a large study from Delhi, which was named as the Delhi Neonatal Infection Surveillance Study, showed us how the extramural units had higher proportion of fungal growths as well as Pseudomonas infections. Now, interestingly, in low middle income countries, including India, the profile of organisms grown both in early and late onset infections are similar. So if you see early onset sepsis and late onset sepsis, still 2/3 of all isolates would be gram-negative, irrespective of whether it is early or late onset sepsis, and 1/3 of isolates tend to be gram-positive. So this is the reason why in neonatal infections, our empirical antimicrobial coverage should include both gram-positive and gram-negative cover. And if we are dealing with a large number of outborn newborns, we must keep in mind multi-drug resistant Pseudomonas as well as a higher proportion of fungal infections that could be lingering. So this data is from the 2016 Lancet publication from the Delhi Neonatal Infections Surveillance Group, or DENIS group. This included 3 tertiary care centers from Delhi, the All India Institute of Medical Sciences, AIIMS, Vardhaman Mahavir Medical College and Hospital, Safdarjung, as well as the CNBC, which was a completely outborn center. Now, surprisingly, the list of bacterial isolates in the Dennis study was topped by the Acinetobacter, which accounted for 22% of all the isolates, overtaking Klebsiella, which was pushed to the second spot, and then E. coli. So the top 3 gram-negative bugs were Acinetobacter, Klebsiella, followed by E. coli, and Pseudomonas coming in later. Whereas among the gram-positive organisms, there was a significant resurgence in coagulase negative staphylococcus. So cons or coagulase negative staphylococcus such as Staph epidermidis, which are usually skin commensals, accounted for 15% of the isolates. And this was after all possible precautions were taken for avoiding contaminants in the blood culture. So there was a standard protocol that was used across these centers for collection of blood cultures after adequate training of the staff. And also adequate precautions were taken for defining what was true bacteremia versus false positive growths or contaminants. So all possible precautions were taken both at the time of sample collection and also at the point of epidemiological definition of what constituted true sepsis. So this did kind of portray that there was a resurgence in cons sepsis, slightly kind of higher than the Staphylococcus aureus related gram-positive infections. So the fact that more and more gram-positive growths, particularly coagulase negative staphylococcal isolates, were coming up from neonatal units came up strongly from this study. Of course, the bacterial pattern was still predominated by gram-negative bacteria. And when we looked at case fatality rates, which is the proportion of newborns with these bacterial isolates in blood dying because of the infection, a surprisingly 80% high case fatality rate of close to 80% was found with Pseudomonas. So Pseudomonas was one deadly bug to grow in blood culture isolates. So this message came in very clearly, and this was followed by Acinetobacter and E. coli, which all of which had a case fatality rate of around 60%. Now, among the gram-positive isolates, case fatality rates were slightly lower, particularly with cons, where around 27% organisms by newborns with con sepsis were succumbing to the infection. Now, again, as we discussed earlier, the pattern of isolates in high-income countries tends to be different between early and late onset sepsis, wherein early onset sepsis in high-income countries tends to be predominated by the group B streptococci and listeria. Group B streptococci being easily explainable because it is the commonest isolated bug from the reproductive tract specimens in mothers. And in late onset sepsis, coagulase negative staphylococcus was the most common bacteria, unlike the gram negative bugs found in the lower and middle income countries such as ours. And fungal organisms also accounted for a significant proportion of neonatal sepsis. Now, in Western countries, cons sepsis is often associated with the presence of indwelling central line catheters like the PICC line. This kind of explained why organisms often isolated from the skin are also found from blood specimens. So this could be related to the possibly to the insertion or to the presence of indwelling central line catheters. Whereas in low middle income nations, there was no particular association between indwelling catheters and lines, and even the presence merely of a peripheral intravenous line can sometimes be the only possible source of introduction of infection. And we know that the pattern in both early and late onset sepsis is similar in low middle income countries, unlike high income countries. And in both early and late onset sepsis, we see 60% gram negative isolates and 30% gram positive isolates. Gram negative isolates earlier it was predominated by Klebsiella, whereas now it is dominated by Acinetobacter. Now coming to the antimicrobial susceptibility pattern. So far we saw the microbiological pattern or profile of bacteria that are isolated from low middle income and high income countries. Now moving next to the other important consideration that determines our antibiotic choice, which is the antimicrobial susceptibility pattern. A whopping vast majority of organisms in low middle income countries are multi-drug resistant. So in one study published in 2013, it was found that up to 86% of Klebsiella strains could be resistant to ampicillin, 71% to gentamicin, and 51% to cefotaxime. Again, among Staphylococcus aureus, more than one half of the isolates tend to be MRSA, which is methicillin-resistant Staphylococcus aureus, and hence clearly these organisms are unlikely to respond to the beta-lactams and may require vancomycin. Among E. coli, again, up to 46% can be cefotaxime resistant. So we clearly get the message that the WHO's recommended first-line empirical antibiotic choice, which is a combination of ampicillin gentamicin, doesn't really work in more than 80% of Klebsiella, which earlier was the most common organism. And this is also likely true with Acinetobacter, which is in all likelihood only going to be more multi-drug resistant than Klebsiella. So clearly, we cannot use ampicillin gentamicin in most units that deal with MDR bugs, which is likely to be the case in units which cater to both outborn and inborn babies. So hence, what is our next option? So different units have different protocols. Now, there are a lot of units which have started adopting a combination of fluoroquinolone in combination with aminoglycoside or aminoglycoside only as a single drug empirical coverage, especially if they are dealing with a good number of inborn babies. Now, our unit, which deals with a combination of inborn and outborn babies, we start with a first-line combination, usually with the third generation cephalosporin and aminoglycoside. So this is not exactly what is written on this particular table. We often use as a second-line choice piperacillin-tazobactam plus amikacin. So in order to have certain degree of antibiotic stewardship prescription policy by all, the unit's policy is that the first and the second line antibiotics can be prescribed by all doctors working in the unit, including the resident doctors, registrars, as well as consultants. Third line antibiotic, which is represented here as the second line, would be a combination of colistin with or without with meropenem, and this is something that is prescribed only by consultants. Now, the addition of meropenem comes in as a necessary step when we are dealing with ESBL producing Enterobacteriaceae, which may be resistant to the beta-lactam and beta-lactamase inhibitor combination. And when it comes to carbapenem resistant gram negatives, then colistin comes in handy. So very often meropenem may be added alone as the third line antibiotic. Colistin would be still kept in reserve. If there is significant clinical deterioration, despite around 48 hours of any antibiotic modification, only then would we consider further modification of the antimicrobial regimen. So whenever there is a usage of a reserve antibiotic drug, there is an antibiotic justification form that needs to be filled in by the consultant who is taking the decision. So at the level of carbapenem or at the level of colistin, the decision is always something that needs to be endorsed by the consultants. Now, one needs to add vancomycin if there are clinical features of staphylococcal infection that are strongly suspected or strongly evident in the form of pustules, skin infection, or the presence of pneumatoceles in the X-ray, or one may consider if the baby has had an indwelling central line like a PICC line for a long time. The final line of defense when all these antibiotics do not seem to be working would be to consider tigecycline, although this is generally not a very great choice for a bacteremia. And this is always something that needs to be only prescribed after the consultation of the microbiology team and the infection control team. And we do take the help of the ID consultants who come in very handy and supportive at this particular juncture. So this is not something that can be adapted at the level of each unit. Every unit would have its own individual local microbiological profile and antimicrobial susceptibility pattern, which would guide this decision. So just like one size doesn't fit all, one policy may not fit all the units. It might have to be fine-tuned based on the microbial pattern that is isolated in each unit and based on the antimicrobial susceptibility pattern. Moving on now to the second case. So the conclusion in the first case is because this baby is a relatively stable baby and who is presenting to us with the community, from the community, and we do not have a culture isolate so far, one could opt between the choice of either a combination of ciprofloxacin and amikacin or piperacillin tazobactam and amikacin. Now, remembering that piperacillin tazobactam is not a great choice for meningitis, one would further base this decision based on the lumbar puncture. In this particular baby, lumbar puncture is planned. Now, if LP is suggestive of meningitis, there are again two options. One could consider using piperacillin tazobactam at the high end of the dose range, which is 100 mg per kg per dose, because it is said that piptaz does have some penetration in an inflamed meninges. But one may consider rationalizing this with the addition of either a carbapenem or a third generation cephalosporin if there is definitely clear evidence of meningitis from the CSF picture. If not, one could consider a combination of piperacillin tazobactam plus amikacin or ciprofloxacin plus amikacin. Then, in this scenario, an option of giving only aminoglycoside in the form of single drug amikacin is also a reasonable option, provided the baby does not have further clinical worsening. We move on now to case scenario 2. We will discuss different types of infections in order to bring out different controversies. Now, this is a 14-day-old term newborn who was brought with complaints of poor feeding and umbilical discharge for 2 days. The baby is sick looking and has tachycardia, normal pulse volume, and normal blood pressure. So the presence of tachycardia and normal blood pressure means that this baby is having compensated shock. And on examination, the baby has erythema around the umbilical stump. There is on palpation, induration of the skin. The umbilical stump is clearly looking infected and the surrounding skin inflamed, and hence we are dealing with omphalitis. So what would be our preferred treatment modality? Now, topical chlorhexidine or betadine application may have some role in relatively localized forms of omphalitis wherein the infection or inflammation may not cross more than 1 centimeter diameter around the umbilical stump and the baby doesn't have systemic signs of bloodstream infection. It is not going to be suitable in this baby clearly because this baby has obvious signs of bloodstream infection. The baby is tachycardic, the baby is sick looking, and the infection around the umbilical stump has disseminated for more than 1 centimeter diameter around the stump, and clearly this looks like more disseminated infection, and hence we would not opt for the topical options. This baby needs systemic therapy. Now, are we going to go head on with vancomycin piptaz or piperacillin tazobactam and amikacin? Let us see what is the best possible choice. Now, again, in omphalitis, the most common organisms would be Staphylococcus aureus tops the list here, which is gram-positive, followed by Streptococcus pyogenes and group B, beta hemolytic streptococci. There is also a proportion of omphalitis that is caused by gram-negative organisms, particularly Pseudomonas and Klebsiella. So when we talk of Staphylococcus aureus, we already saw that up to 56% of Staphylococcus aureus in India can be methicillin resistant or MRSA. So this needs to be kept in mind when we are dealing with a sick baby with omphalitis, where straight away we may have to think of something that covers MRSA, which would be vancomycin. If we are not concerned about the methicillin resistance factor, we could still consider starting the baby on something like piptaz and amikacin, which would fairly give coverage for methicillin sensitive Staphylococcus and also gram-negative organisms, including Pseudomonas. However, since this baby has compensated shock already, it would be more reasonable to start with vancomycin and a gram-negative cover in the form of either amikacin or piperacillin tazobactam, and subsequently downgrade the antibiotics maybe 48 hours later if we get a culture report which is showing sensitivity to methicillin or methicillin-sensitive Staph aureus. It could be considered if there is also some clinical improvement and the blood culture report endorses the presence of methicillin sensitivity. So this is the usual policy if the newborn has signs of severe umbilical infection in the form of redness, induration and swelling extending for more than 1 centimeter around the umbilicus or presence of systemic signs of bloodstream infection. We begin with IV antibiotic coverage to cover methicillin-resistant Staph aureus with vancomycin or cloxacillin if the baby is not very sick. And add piperacillin tazobactam to cover gram-negatives, including Pseudomonas. However, if it is localized infection with redness and swelling extending for less than 1 centimeter around the umbilicus, topical antiseptics would suffice. Now, is there a role for prophylactic topical antiseptics to prevent umbilical infection or omphalitis? There are some studies, large cluster randomized trials, where 4% chlorhexidine gluconate has been used prophylactically for swabbing the umbilical stump. And this strategy has been shown in large studies performed in the lower middle income countries, particularly in the Southeast Asia subcontinent, to show that there is some evidence to prevent omphalitis or early onset neonatal sepsis. So consider local 4% chlorhexidine gluconate or 2.5% povidone iodine if there is only localized infection. However, the evidence that we discussed did not really translate into a recommendation of routine umbilical antiseptic applications to prevent the omphalitis. In presence of definite omphalitis, which is localized, there could be a role for topical antiseptics, and chlorhexidine has come up in a big way in this particular scenario. So again, to summarize, localized omphalitis, there is a role for local antiseptics, and 4% chlorhexidine could be a very viable, reasonable option. 2%, 2.5% povidone iodine is also an alternative, but we must remember that there could be skin inflammation and accidental iodine absorption, especially in preterm babies with fragile skin. Now, in the case of severe umbilical infection, there is always no place for doubt. The treatment would always be in the form of systemic antibiotics, and the antibiotic coverage must include a combination to cover both gram-positive and gram-negative organisms, keeping in mind resistant bugs, particularly MRSA coverage in the form of vancomycin for sick babies. Now we move on to case scenario 3. This is again a different type of infection. This is a term neonate coming with a birth weight of 3,200 grams and was admitted on day 10 of life with paucity of movements of the left hip. The neonate was admitted for 48 hours at birth in view of transient tachypnea of newborn and required nasal bronch oxygen as well as intravenous fluids for 24 hours in the NICU. So this baby has had a brief NICU stay at birth and subsequently was discharged and now is readmitted on day 10 of life with relative paucity of movements of the left hip. So at admission, the left hip as well as knee joints are swollen and tender. Systemic examination is otherwise normal. So the first possibility that comes to our mind is possible septic arthritis. This could have been because of a seeding of bacteria which may have followed bacteremia that occurred during the first admission. So how are we going to decide the empirical first choice of antibiotics for this neonate? Would we choose ampicillin, gentamicin, ciprofloxacin, amikacin, vancomycin, piperacillin, tazobactam, or vancomycin, meropenem? Now, again, septic arthritis is something that is rapidly evolving. Unlike data from across the world, Indian data indicate that septic arthritis is again predominated by gram-negative bacteria, accounting for up to 61% of positive cultures sent in newborns with septic arthritis group Klebsiella and Pseudomonas. So this could probably be because of the prevalent pattern of antimicrobials or prevalent pattern of bacteria that are isolated from the blood culture isolates, because after all, septic arthritis is usually something that follows bacteremia. Now, data from a center in South India, Child Trust, that looked into this particular group of infections and published this data, showed that again in similarity to the Indian profile, up to around 60% of infections were gram negative and 40% were gram positive. Now, the most common gram-negative bacilli in septic arthritis was found to be an organism called as Kingella kingae. Now, this is excellently responsive to intravenous third-generation cephalosporins. Hence, in a sick neonate with septic arthritis, again keeping MRSA in mind, one would consider starting a combination that has vancomycin. So that would be IV vancomycin plus meropenem that would cover the resistant gram-negative isolates as well, because we know that in India, 60% of septic arthritis is going to be due to gram-negative bacteria. Only 40% would be secondary to Staphylococcus aureus. So in a sick neonate with septic arthritis, it is important to cover methicillin-resistant Staphylococcus aureus as well as resistant gram-negative bacilli, and hence the combination preferred would be IV vancomycin and meropenem. Whereas in a non-sick neonate or a stable neonate coming with septic arthritis, one could consider a combination that includes slightly narrower spectrum gram-negative coverage Maybe until Pseudomonas, so one may consider giving IV vancomycin plus piperacillin tazobactam, and this could be further modified based on the culture report. Now, the possibility of using clindamycin, which will cover both MSSA and MRSA, as well as anaerobes, is something that is to be explored more and more in neonates. We have used clindamycin in some neonates with bone and joint infection, and it generally works reasonably well, and not many side effects have been reported. And now, when in the particular context of Kingella, which was found in the South Indian series to be the most common gram-negative bacterial isolate in septic arthritis, the drug that works very well is IV ceftriaxone. So ceftriaxone clindamycin combination is also something that could be considered if the profile of septic arthritis in our unit is similar to what was reported in South India. In general, the combination for septic arthritis would be a combination of IV vancomycin to cover methicillin-resistant staph aureus and a fairly broad-spectrum gram-negative coverage, meropenem or piperacillin tazobactam based on the baby's sickness level. Now, overall duration of treatment for septic arthritis is kept at 4 to 6 weeks, of which the parenteral duration usually is to be kept at a minimum of 7 days to 10 days, followed by a slightly higher dose oral antibiotics. Usually, one may consider giving either oral cefalexin at 100 milligrams per kg per day, or oral amoxicillin clavulanate can also be considered. If we have a clear-cut culture evidence of methicillin-resistant Staphylococcus aureus, one could consider giving oral linezolid as well. Now, switching from IV to oral would be considered only if the neonate shows signs of clinical response in the form of becoming afebrile with local signs of inflammation becoming considerably better and accompanied by decline in the inflammatory markers like C-reactive protein and white cell counts. Moving on next to a different scenario, this is early onset sepsis. So you are dealing with a 34 weeks newborn who delivers with a birth weight of 1,995 grams. The baby is otherwise asymptomatic, is born to a primary gravid mother with history of leaking per vaginum for 30 hours. So this mother has prolonged preterm rupture of membranes. So this is generally taken as a duration of more than 18 to 24 hours. So leaking per vaginum for more than 30 hours clearly becomes prolonged. She also has fever of 39 degrees Celsius on 2 occasions immediately prior to delivery, and there is no history of foul smelling liquor. The resident is concerned and he shifts the baby to the neonatal ICU. So there are multiple risk factors in this baby for early onset neonatal sepsis. These include the presence of prematurity in the form of the baby being a 34 weeks baby, low birth weight baby, birth weight 1995 grams. The mother has prolonged preterm rupture of membranes as well as history of maternal fever. Now, what would be the further course of action? So these are the different steps that are in front of you. Would you start IV antibiotics and perform LP? Would you observe this baby start antibiotics only if there is clinical deterioration? Would you perform a sepsis screen and start antibiotics based on the sepsis screen if it comes back positive? Or would you just start antibiotics after sending the culture and perform LP if the baby's culture comes back positive? Now let's see the answer to this question now. First, taking into consideration the risk factors for early onset sepsis. So various groups, including the PGI, the National Neonatology Forum, and Western guidelines coming from the American Academy of Pediatrics have laid down the risk factors for maternal risk factors for early onset neonatal sepsis with some variations amongst the different groups. So in general, these are all the risk factors: being born low birth weight or premature below 37 weeks, below 2,500 grams, fever in the mother more than 37.8 degrees Celsius within 2 weeks prior to the delivery, or the presence of clinical chorioamnionitis, which again has its own definitive criteria, the presence of foul-smelling liquor, rupture of membranes prolonged more than 24 hours, history of even more than 3 clean pervaginal examinations or a single unclean pervaginal examination, the presence of prolonged labor, which is defined as the combination of first and second stage of labor beyond 24 hours, presence of asphyxia, and a positive maternal high vaginal swab for an organism that is incriminated in neonatal sepsis. Now, when we are dealing with a newborn with such risk factors, one or more of such risk factors, one would consider starting antibiotics if, again, this is based on one school of thought, if there is at least 2 antenatal risk factors along with a positive screen that is performed between 6 to 12 hours of life, or the presence of at least 3 or more risk factors straight away without waiting for the sepsis screen. So in this particular baby, there were at least 3 risk factors. The baby was born preterm and low birth weight. The mother had prolonged rupture of membranes, and she also had the history of significant fever spikes that were present. So taking these 3 risk factors into consideration, going by this particular school of thought, one would possibly consider starting IV antibiotics without even waiting for the sepsis screen results. But you may still want to send a screen just to understand what is the baseline hematological profile of the baby, like trying to understand what is the basic baseline white blood cell count, baseline CRP, baseline platelet count, etc. Now, there are some exceptions to this rule. If a mother has presence of clinical chorioamnionitis, which is defined by the presence of significant fever, with the presence of at least 2 of the other criteria, which would be one of the following: the presence of foul-smelling liquor, the presence of uterine tenderness between contractions, the presence of maternal leukocytosis, or the presence of maternal or fetal tachycardia. In these cases, we will definitely need to investigate the baby. If the baby is born full term, we may consider initiating antibiotics if the sepsis screen comes positive, or if the neonate has any early sign of sepsis, any early sign of clinical deterioration. In a preterm baby with a mother with clinical chorioamnionitis, however, we may just take an exception straight away and start antibiotics even if the preterm neonate is asymptomatic. So if the mother has frank clinical chorioamnionitis, remember that if the baby is born preterm, you may not want to wait for any of the other risk factors or the sepsis screen report. You may just want to start the baby on antibiotics, even if the baby is asymptomatic. In a term newborn born to a mother with clinical chorioamnionitis, then one would start antibiotics at the earliest clinical sign of sepsis or with a positive sepsis screen. Now, next coming to the question of whether or not to perform lumbar puncture. Now, the above baby did not have any evidence of clinical chorioamnionitis, and hence, based on the presence of 3 significant risk factors for early onset sepsis, we would consider starting antibiotics. Nevertheless, although the baby is asymptomatic and although the mother did not have features of chorioamnionitis. Now, lumbar puncture would be deferred in this particular scenario. This is because lumbar puncture is to be done only in all neonates suspected to have sepsis and being started on antibiotics, except in 2 situations: asymptomatic babies with risk factors, such as the index case, or preterm newborns with respiratory distress and no other fresh risk factors. So the answer, or the most kind of reasonable clinical approach in this particular baby, who is asymptomatic baby born to a mother with 3 risk factors, would be you start antibiotics, send a sepsis screen and blood culture, watch the baby closely for any clinical deterioration. You did not do lumbar puncture straight away, but we would do lumbar puncture if the baby develops any clinical signs of sepsis. However, if the baby remains asymptomatic and the sepsis screen reports are reassuring, then we would stop antibiotics at 48 hours as and when we get the culture reports back as negative. Now, coming next to case scenario 5, a term neonate presents with icterus up to thighs on day 25 of life. The baby's current weight is 3,050 grams against a birth weight of 3,030 grams, and the clinical examination is unremarkable. Feeding behavior is assessed and appropriate guidance is provided to the mother. The baby has indirect hyperbilirubinemia with a direct fraction of 0.3 milligrams per deciliter and total serum bilirubin of 11 milligrams per deciliter. So you are dealing with prolonged indirect hyperbilirubinemia. Hence, the baby is investigated for hypothyroidism, urinary infection, and bacteremia by doing a thyroid profile, which is normal, a blood culture, which is sterile, and urine routine that shows significant pyuria with 10 white blood cells per high power field with white blood cell casts. The microbiologist informs you on phone that the urine is showing growth of a gram-negative bacteria and that the species will be available tomorrow. Now, what is your choice for the empirical antibiotic cover? These are the 4 options. So, in any case of uncomplicated urosepsis, where the baby is absolutely asymptomatic, you may consider treating the baby with a single antibiotic. You can either choose to give piperacillin tazobactam alone or amikacin alone, and then If the baby has a urine culture that is growing a certain bacteria which is isolated, you can base the further treatment based on the sensitivity pattern. However, in the presence of bacteremia, we generally prefer to use a combination of gram-positive and gram-negative coverage in the form of piperacillin tazobactam with amikacin. So in this particular scenario, you're quite justified in using only a single drug in the form of piperacillin tazobactam. I'll be finishing with this last case scenario. This is a self-explanatory picture of a newborn that presents with conjunctival injection, chemosis, and late edema on day 4 of life. Now, when we have a baby who is presenting to us with conjunctivitis, various possibilities come to us in front of us. This could include H influenza, staph aureus, E. coli, where topical erythromycin or gentamicin drops would suffice. Tobramycin is also used. We may have the possibility of chlamydial conjunctivitis, where systemic therapy with oral macrolide is generally preferred for a duration of around 14 days. But the most dangerous type of conjunctivitis that needs to be ruled out is the gonococcal conjunctivitis. This is particularly likely when you are dealing with a baby with significant chemosis and lid edema, like this baby has. Here, the drug of choice would be a single dose of intravenous or IM third generation cephalosporin in the form of ceftriaxone 25 to 50 milligrams per kg, combined with topical erythromycin, and this prompt treatment is absolutely essential to prevent corneal ulcers. So I shall be finishing with this discussion with the 10-point rule given by Isaacs, who is someone who has worked closely in neonatal infections, and he gives us this 10-point mantra or mandate to curb antimicrobial resistance in neonatal units. Firstly, always take cultures from blood or perhaps CSF and urine before starting empirical antibiotic cover. Very important step. Now, we should never under evaluate the value of blood cultures, especially when we have a great microbiological backup. So always remember to take cultures and trust the microbiology team. 2, use the narrowest spectrum of antibiotics possible. Almost always a penicillin like piperacillin or ticarcillin and possibly a combination of a simple aminoglycoside might be enough, might be sufficient in majority of the cases. Third, do not start treatment as a general rule with a third generation cephalosporin like ceftriaxone or cefoperazone, or empirical coverage with a carbapenem like meropenem, because this can lead to a large incidence of ESB producing bugs, of course, with rare exceptions. And fourth, try to develop local or national antibiotic policies. Fifth, trust the microbiological lab and rely on the blood culture results. Prolonged treatment of newborn babies merely on the basis of a positive CRP or a positive procalcitonin, even in the presence of negative blood cultures, can lead to a lot of overtreatment. Sixth, do not believe that abnormal results of a non-specific test like a raised serum C-reactive protein in a well neonate means that the baby is definitely septic. Definitely not. A baby who is having significant clinical signs of infection may still be considered as a justifiable reason for an empirical antimicrobial coverage, but never ever go by the results of a positive C-reactive protein in a stable or a well neonate as a justification for the prolonged usage of empirical antibiotics. Seventh, if blood cultures are negative at 2 to 3 days, in most of the cases, it is almost always safe and appropriate to stop antibiotics unless the baby has already come with prior broad-spectrum antimicrobial cover. This may lead to a low yield in the blood cultures or because of inappropriate technique of collecting blood cultures. Eighth, try not to use antibiotics for long periods. Ninth, treat sepsis and not colonization. Hence, the role of sending routine surveillance cultures from the skin or umbilical swab or from the eye may not yield much value. Use endotracheal cultures or central line tip cultures very, very rationally, only if there is a clinical evidence of an infection. Like you may consider sending endotracheal cultures in a newborn who is clinically having signs of suspected VAP. 10th, do your best to prevent nosocomial infection by reinforcing infection control rather than investing on broad-spectrum antibiotics, particularly invest on hand washing. So with those 10-point rules from ISACs, I shall conclude today's presentation. Thank you all for joining us. Please leave your comments or questions on the chat box or on the Zoom session. So I presume that there are no questions for the day. And if not, I shall thank all of you. Thank you, Padma Sinha sir, for your compliment. I thank you all for joining us today, and please do join us for our subsequent sessions, Friday Cuddles online neonatology lectures in the subsequent weeks as well. Thank you, one.